Hi, my name is Kara Watson and I am a social work student at Vincennes University. For my speech assignment, I will be discussing my research on cognitive behavioral therapy. During this video, I will be explaining what cognitive behavioral therapy is, the history behind it, and the primary components. Cognitive behavioral therapy is a manner of thinking that is motivated by hypothesis testing and case formulation. Cognitive behavioral therapy works best with individuals who are not making progress in response to conventional methods. Cognitive behavioral therapy is the view that the human mind is not an inactive receptacle of environmental and biological influences and sensations, but instead that individuals are actively involved in constructing their reality. To understand a person's emotional responses to particular life events, it's important to discover the meaning they attach to these events. This is their subjective construction of reality. This conceptual cornerstone of cognitive behavior therapy derives from ancient Stoic philosophers such as Epictetus and Marcus Aurelius, and their view on mental control, like our thoughts and beliefs are within our control. In more modern times, Aaron Beck developed cognitive behavior therapy in the 1960s. He was an American psychiatrist who was a professor in the Department of Psychiatry at the University of Pennsylvania. He is regarded as the father of cognitive therapy and cognitive behavior therapy. His pioneering methods are widely used in the treatment of clinical depression and various anxiety disorders. Cognitive behavior therapy has been extensively researched and found to be effective in a large number of outcome studies for psychiatric disorders, including depression, anxiety disorders, eating disorders, substance abuse, and personality disorders. It can also be used in conjunction with medication for serious mental disorders such as bipolar disorder and schizophrenia. Cognitive behavioral therapy has been adjusted and studied for children, adolescents, adults, couples, and families. Cognitive theory is based on an information processing model which posits that during psychological distress, a person's thinking becomes more rigid and distorted. Judgments become overgeneralized and absolute, and the person's basic beliefs about self and the world become fixed. This is distorted thinking. This distorted thinking underlies all psychological disorders. These distortions usually stem from deeper dysfunctional beliefs that are activated during emotional distress. Common information processing errors or biases found in emotional distress include all or nothing thinking, jumping to the conclusions, confirmation bias, mind reading, labeling, and emotional reasoning. Teaching clients how to identify and correct these errors or biases shifts their thinking from reflexive to reflective information processing, thereby slowing it down in order to improve problem solving and decision making. This shift is also known as metacognitive awareness, which is thinking about thinking. When working with a client who has emotional disorder, cognitive behavioral therapy focuses on 3 levels of thinking. Negative automatic thoughts are specific to the situation and involuntarily pop into a person's mind when experiencing emotional distress such as depression or anxiety. These thoughts are plausible to the person and are difficult to turn off. Negative automatic thoughts often lie outside of immediate awareness but can quickly be brought on to the client's attention by asking standard cognitive behavioral therapy questions like what was going through your mind at that moment when you were late to class. Underlying assumptions guide behavior and set standards. These are the second level emotional disorders. These assumptions and rules are often unarticulated and can be difficult for clients to detect. Underlying assumptions are usually identified by their if, then, or unless then construction, and rules are usually expressed in must and should statements. These assumptions and rules are the means by which individuals hope to avoid coming face to face with their negative core beliefs. Assumption and rules are cross-situational and are also known as intermediate beliefs because they lie between negative automatic thoughts and core beliefs. Core beliefs or schemas are the third level of thought and the deepest. Negative core beliefs are overgeneralized and unconditional. They are usually formed through early learning experiences and lie dormant until activated by relevant life events. Not every client will need the 3 levels of examination. For some therapists, it may be sobering to learn that pretty much all the research supporting the effectiveness of cognitive behavioral therapy is based on cognitive behavioral therapy that focuses on negative automatic thoughts and sometimes dysfunctional assumptions, not core beliefs. Dobson and Dobson suggests that it is quite likely that negative core beliefs change gradually without directly modifying them if clients continue to think and act over the longer term, an indirect process of chipping away at core beliefs. Cognitive schemas are organized structures of stored information that contain individuals' perception of self and others, goals, emotions, and memories. Cognitive behavioral therapy can be used for children with a history of trauma and abuse. Trauma-focused cognitive behavioral therapy is used for children who are 9 to 15 years old who have post-traumatic distress disorder symptoms as a result of child abuse and related traumatic experiences. Empirical evidence is strongest for cognitive behavioral approaches over other forms of psychotherapy for efficacy of resolving PTSD and other anxiety-related symptoms in children. Trauma-focused cognitive behavioral therapy is recommended for treating the specific problems of abused children. This treatment approach incorporates psychoeducation, coping skills, training via behavioral interventions such as emotional expression and relaxation, and cognitive interventions such as coping, self-talk, and problem solving. Gradual exposure techniques are utilized for trauma processing. A key consideration in adapting an anxiety-based approach to the treatment of PTSD symptoms was that anxiety is about the current and future threats, whereas PTSD, while an anxiety disorder, has much to do with past events. Children who have PTSD symptoms are processing trauma and or its residuals in a way that involves ongoing stress. A second major consideration of the development of this treatment program has been the psychosocial context of traumatized children. Traumatic experiences often affect the relationships children have with their parents, family members, peers, and others. A child's attachment experience can make an impact on the development of the relationship with the therapist, and time spent by therapists exploring and strengthening the child's psychosocial context can provide ample opportunity for rapport building. This program is not designed specifically to address attachment issues, but it is anticipated that the facilitation of a positive therapeutic relationship will be helpful for children, some of whom may have had little experience of safe, secure attachment relationships. The essential elements of cognitive behavioral therapy include in this treatment are the centrality of the cognitive behavioral conceptualization, the collaborative nature of therapeutic relationship, the active involvement of the child, the use of Socratic questioning and guided discovery, explicitness of the therapist, the importance of emotions, the central role of exposures, the contextual framework. Phase 1, psychosocial strengthening, to provide an orientation to therapy, build rapport, elicit hope and active participation, gain information about the child's work and view of himself, explore family relationships, and identify social supports. Phase 2, coping skills, which is 5 sessions, based on cognitive behavioral techniques which encourage children to cope directly with their anxiety and trauma symptoms rather than relying on avoidance behaviors to reduce personal stress. They use the STAR plan: scary feelings, thinking bad things, activities that can help, ratings, and rewards. Phase 3 is trauma processing, a series of sessions based on a cognitive behavioral model of how trauma symptoms are maintained. Phase 4, special issues and completion therapy. Traumatized and abused children often present with a range of issues. This phase enables more specific intervention on residual issues which continue to affect the child. The trauma-focused cognitive behavioral therapy approach is described session by session. Sessions are designed to take about an hour, although it is recommended that 1.5 to 2 hours are allowed for the exposure sessions, as a longer time frame may be required to allow traumatic events to be processed. Each session begins with a statement of overall purpose, followed by the specific goals and materials required. The sessions begin with a review and agenda setting. Activities follow, and the session begins with out of session task setting and a wind down activity. Phase 1 provides a framework and activities for therapeutic engagement. Phase 2 provides activities for alleviating symptoms and building coping skills. Phase 3 and 4 offer processes for healing underlying causes of problems. As a social worker, I want to work with children, and I think that this therapy is the best one to use for children who have PTSD, who have been abused, who have been traumatized by their experiences